Now, topics for today's discussion is SAM management. What are the WHO's guidelines for the management of SAM? That is severe acute malnutrition. It is defined as for age more than 6 months any child who has weight for height less than 3 standard deviation and or mid upper arm circumference of less than 11.5 centimeters and or edema of both the feet and visible severe wasting. For children whose age is less than 6 months, there is weight for height less than 3 standard deviation and or edema of the feet without any known causes of edema of the feet, including the nephritic syndrome or congestive heart failure. Now, visible severe wasting is to be considered in children more than 6 months and whom length is less than 45 centimeters. And for those less than 6 months, other causes of edema including nephritic and CHF need to be ruled out. Severe acute malnutrition with complications means with severe edema of grade 3 or mid upper arm circumference of less than 11 centimeters, child is not well, clinically not alert, there is loss of appetite, patient need to be given inpatient care. Now, without complication, when edema is of grade 1 or 2 with mid upper arm circumference of less than 11.5 centimeter, but child has good appetite, clinically alert, well, OPD basis management of the SAM patient needs to be done. When SAM patient is without complication, there is mild edema, but the child is well, clinically well, alert, active, accepting orally, you have to manage the child on OPD basis. You have to initiate the home feeds, primarily cereal pulses based. In order to make it energy dense, add sugar, oil, milk. Ensure 175 kilocalories per kg of the body weight per day. Along with the breastfeeding, feeding should be given at the rate of 6 to 8 times per day. Hygiene need to be ensured. Oral amoxicillin for 5 days at the age appropriate dose. Then in case vitamin E deficiency signs are there, you have to give mega dose of vitamin A. Albendazole is to be given 400 milligrams single dose, and then age appropriate vaccines and catch-up vaccination need to be given to the child. In case the patient is not sensitive enough to understand the how to give the home feeds, in those scenarios, if ready to eat food is available for some patients, that can also be given to the patient's parents, and they need to be briefed how it is to be given and what is the importance of it. Hygiene is to be ensured strictly because it has a great impact in controlling the infections in those who are immunocompromised. SAM patients, because of weakness, because of malnutrition, they are immunocompromised, they can acquire infections earlier. Sensory stimulation should be given to the child. Patient needs to be told how to make the child to play, how to use the toys. Age appropriate plays need to be encouraged. Home visits by the health workers on daily basis, lately twice a day to be given. Now, what is the role of health worker? Health worker has to visit on regular basis. He has to assess what is the amount of the feed which is given to the child, that is intake assessment. Any issues related to the feed need to be solved. Any medical problems associated need to be reported to the doctor, and weight need to be recorded. Now, broadly, malnutrition is of two types. One is marasmus, another is kwashiorkor. Marasmus is when the patient gives a severely wasted look. The ribs are visible, there is severe wasting of the muscle, thin and brittle hairs are there, and Simon facies. In marasmus, there is deficiency of the nutrition as a whole, but in kwashiorkor, there is protein energy malnutrition. Primarily, there is loss of proteins, there is deficiency of proteins. Patient has got moon faces, there is bulging abdomen, there is ascites, and there are thin and brittle hairs. What are the signs of malnutrition from head to toe? In face, we can have either moon faces in kwashiorkor and Simon faces in marasmus. In eyes, we can have the signs of vitamin A deficiency. In mouth, we can have got angular stomatitis, chelotis, glossitis, cheilitis, bleeding from the gums because of vitamin C deficiency. And in teeth, we can have enamel mottling, delayed eruption. Hairs are dull, sparse, brittle hairs, easily pluckable, hypopigmented, alternated bands of light and dark hairs called the flag sign, broomstick eyelashes, alopecia. In marasmus, because of the muscle wasting, there is loose and wrinkled skin. And in kwashiorkor, because of protein deficiency, there is shiny and edematous skin. We can have follicular keratosis, we can have hypopigmented, we have got flaky paint dermatosis, erosions, poor bone healing. Nails, we can have spooning of nails, thin and soft nail plates are there, fissures are there. Because of the severe muscle wasting, which can be seen primarily at the buttocks and thigh. Because of hypocalcemia, chvostic or trocheo signs can be there. In skeletals, we can have bowing of the legs, we can have signs of vitamin D deficiency, abdomen can be distended as seen in kwashiorkor. Because of hepatomegaly along with fatty liver, and ascites can also be present. In heart, we can have dilated cardiomyopathy, bradycardias, hypotension, reduced cardiac output. Neurologically, global developmental delay is there, reflexes are lost. Have severe anemia, we can have petechiae, bleeding, diathesis, lethargic, apathic, irritable on handling change. Roughly, while we are managing the patient of SAM, we have to remember a mnemonic. Shielded, that is S is for sugar deficiency, hypoglycemia to be corrected, hypothermia, infection, electrolyte imbalance, dehydration and deficiency of micronutrients. These are to be addressed. While we are managing a patient of SAM, there are two phases. First is the stabilization phase, which is for the initial first week. Then is rehabilitation phase, which is from the second week onwards till the 6th week. Now we have learned the mnemonic shielded, and all these things are covered in the 10 steps. The first is hypoglycemia, low blood sugar need to be taken care. Low temperature, hypothermia, then dehydration is to be taken care. Electrolytes need to be deficiency need to be covered. Infections need to be treated. Micronutrient deficiencies need to be corrected. Feeding to be started but cautiously. Catch-up growth need to be considered. Then sensory stimulation of the patient need to be done. Then we have to prepare the patient for follow-up by actually sensitizing the patients that what is the importance and how actually you need to take care of the baby. Now the first step for the management of a patient of SAM is the low blood glucose. What is low blood glucose? When it is less than 54 milligram per deciliter, we usually check it using glucometer. Now if the patient is asymptomatic, there are no symptoms, what we have to do? We have to give 50 ml of 10% of dextrose solution orally, and if not accepted orally, then we can give it through the NG tube, and it is to be followed by the feed. Now we have to start F75 diet to be started, to be given every 2 hourly for initial 1 day at least, and initial feed is to be given 1/4 25% in 4 divided doses every 30 minutes. It need to be given. The patient need to be kept warm. Now the SAM patients who are symptomatic for hypoglycemia in the form of letharginess, unconsciousness, seizures and peripheral circulatory failure. Initially you have to give 10% of dextrose IV 5 ml per kg. Along with that 50 ml of 10% of dextrose to be given by NG tube. Again feed to be started every 2 hourly. Initial feed to be given 25% every 30 minutes for 1 hour. You have to keep the baby warm and you have to start the antibiotics at the earliest. Now second step is hypothermia. Hypothermia is when axillary temperature is less than 35 degrees Celsius or less than 95 degrees Fahrenheit, or rectal temperature is less than 35.5 degrees Celsius or less than 95.5 degrees Fahrenheit. You have to remove the wet clothing of the patient. You have to cover the baby with the warm clothes. Head is to be covered with the scarf or the cap. The hands need to be covered, the feet need to be covered. In order to keep the baby warm, you can use overhead warmers, heat convectors, skin to skin contact with the caregiver or mother can be given. You have to monitor the temperature every 30 minutes. You have to, in order to prevent hypothermia, again you have to cover the child, remove the wet clothing. You have to keep the baby in contact with the mother. The temperature need to be maintained. The room temperature should be between 25 to 30 degrees Celsius. All the windows need to be kept closed. You have to touch the baby after warming your hands. You have to cover the baby properly. You have to remove the wet clothes, avoid sponging or bathing the baby, and start antibiotics immediately and start feeding immediately in order to prevent hypothermia. Now for dehydration part, you don't have to give IV fluids to the SAM patient until and unless the child is in shock. You have to start with the Resomol, the rehydrated solution for malnourished, at the rate of 5 ml per kg every 30 minutes for initial 2 hours orally or through NG tube. After that, you have to give at the rate of 5 to 10 ml per kg, alternating with the feeds for the remaining 10 hours. Amount to be given depends upon the amount of fluid loss in the stools or an eagerness to the drink. Now, while you are correcting the dehydration using Resomol, you have to monitor hourly. You have to see for the signs of overloading. You have to see if pulse rate increases by 15 beats per minute and respiratory rate increases by 5 beats per minute. Then these are the signs of overhydration. You have to stop the Resomol when the child is less thirsty, passing urine, skin pinches less slow, eyes are less sunken, mouth is moist, there are no tears, child is less lethargic, pulse is improved and respiratory rate is improved. Now, in order to prevent dehydration, give Resomol at the rate of 5 to 10 ml per kg after each loose watery stool. You have to continue breastfeeding and initiate F75 formula feed at the earliest. Now, this is the flowchart that shows the management of SAM with diarrhea. Take pre-management weight, and after giving Resomol at the rate of 5 ml per kg every 30 minutes for 2 hours, take post weight. Depending upon child has gained weight is stable or lost, you have to do further management and you have to decide about the Resomol, right? Just go through the content. Then if the patient with SAM is in shock, then what you have to do? So you have to start IV fluids only when there are signs of shock, child is lethargic or has loss of consciousness. You have to weigh the child, estimate the weight. If the child can't be weighed, assume the weight. Give oxygen, keep the baby warm, start IV line and give IV glucose, 10% of glucose, 5 ml per kg. Thereafter, you have to start IV fluids at the rate of 15 ml per kg over 1 hour, either RL in 5% dextrose or half normal saline with 5% glucose or RL to be given. You have to keep monitoring the pulse and the breathing rate for any signs of overhydration every 10 to 15 minutes. Now, if there are signs of improvement, means pulse rate and respiratory rate falls, you have to repeat the same fluid 15 ml per kg over 1 hour more. And then you can switch to oral or NG rehydration with Resomol at the rate of 5 to 10 ml per kg, alternating with the feeds. Now the remaining two scenarios are after giving 15 ml per kg over 1 hour, there is either no improvement or there is further deterioration, that is RR increases by 5 beats per minute and PR increases by 15 beats per minute. You have to assume that the child has septic shock. Start maintenance IV fluids at the rate of 4 ml per kg per hour. Start antibiotics. You can give 10 ml per kg of the fresh whole blood and transfuse over 3 hours. If the signs of heart failure are there, then packed RBCs at the rate of 5 to 7 ml per kg to be given. In order to prevent the overload, you have to give Lasix or furosemide at the rate of 1 ml per kg at the start of the transfusion. Now, another scenario in SAM patient is when the HB is less than 6 and there is severe respiratory distress. You can give fresh whole blood at the rate of 10 ml per kg slowly over 3 hours. But if the signs of heart failure, 5 to 7 ml per kg of packed RBC is to be given. Furosemide 1 ml per kg IV at the start of the transfusion is to be given. In case of corneal ulceration, emergency eye padding to be done, vitamin A first dose to be given. Based upon the age, you have to instill 1 drop of atropine 1% into the affected eye and you have to eye pad the eye in order to prevent further ulceration. Now, electrolyte deficiencies need to be considered. Potassium need to be given. Potassium supplement to be given at the rate of 3 to 4 milliequivalent per kg per day for at least 2 weeks. Potassium, the most common available preparation is potassium chloride, which contains 20 milliequivalent per 15 ml, and then it should be diluted with the equal amount of water. If the total dose is more than 10 ml, you can divide it into 2 doses, right? Then second is your magnesium. On the day first, 50% of magnesium sulfate is to be given IM once at the rate of 0.3 ml per kg, and the dose should not exceed more than 2 ml. From day 2nd to day 14, 0.2 to 0.3 ml per kg of the magnesium sulfate to be given dissolved or mixed with the feeds only. Now in sick patients, you will start with IV antibiotics, IV ampicillin at the rate of 50 mg per kg per dose 6 hourly for at least 2 days. Then when the patient is little well, you can switch over to oral amoxicillin at the rate of 15 mg per kg 8 hourly for 5 days and add gentamicin or amikacin to it for the total of duration of 7 days. If there is no improvement after 48 hours of starting the antibiotics, you can switch over to cefotaxime or ceftriaxone at the recommended doses. Now, in order to prevent the infections, you have to follow the hand hygiene practices. In case if the child is more than 6 months and not immunized, or if the child is more than 9 months and had been vaccinated before the age of 9 months, you can give the measles vaccine to the child. Now, what is the dose of vitamin A in SAM? Less than 6 months, 50,000 IU, 6 to 12 months, 1 lakh IU. If weight is less than 8 kg but the age is more than 12 months, again 1 lakh IU. But if the age is more than 1 year and weight is also more than 88 kg, 2 lakh international unit is to be given. Same dose to be given on day 1, day 2 and day 15 to all the children with the SAM. So recommended 3 doses are to be given. Now all the micronutrient supplements to be given for at least 2 weeks. Multivitamin supplement should also contain, along with vitamin B complex, vitamin A, C, D, E and B12, and it has to be given twice the recommended daily allowance, 5 ml OD. Folic acid 5 mg on day 1 followed by 1 mg per day. Elemental zinc at the rate of 2 mg per kg per day. Copper at the rate of 0.2 to 0.3 mg per kg per day. Once the child started gaining weight and there is no edema and no diarrhea, add 3 mg of elemental iron per kg per day. Now you have to initiate the feeding. F75 diet is to be given, the starter diet initially. It has to be given at the rate of 130 mg per kg per day. It provides 100 kilocalories per kg per day and 1 to 1.5 gram of proteins per kg per day. Initially 8 to 12 small feeds are to be given. If gross edema is there, you can reduce the volume to 100 ml per kg per day. Keep a 24-hour input and output chart. Measure the amount of feed left by the child. Record the leftover. If child has poor appetite, try to finish the feed, or if unfinished, re-offer later. Use NG tube in case if child accepts less than 80% of the amount of feed. Continue breastfeeding along with the F75 diet. If there is persistent diarrhea, initially low lactose based diet is to be given, which is cereal based. If diarrhea again persists, then lactose free F75 diet is to be given. Now in catch up, we have to give F100 diet. Once the appetite of child returns in 2 to 3 days, will encourage higher intake, increase the volume offered at each feeds, and you'll simultaneously decrease the frequency of feeds to 6 feeds per day. Along with that, continue breastfeeding, increase the calories. Once you start the F100 diet, the calories are increased from 150 to 200 kilocalories per kg per day and protein from 4 to 6 gram per kg per day. Add complementary feeding. Now the main role is also to sensory stimulate the patients. You have to make an environment where child is to be given the toys. Sensory stimulation is to be done at least for 30 minutes a day. Age appropriate physical activity need to be encouraged. It can be either primary failure to respond, when by day 4 failure to regain appetite, when by day 4 failure to start losing edema, when by day 10 there is presence of edema, when there is failure to gain weight at least 5 gram per kg per day by day 10. Secondary failure is when during the rehabilitation phase there is failure to gain weight by at least 5 gram per kg per day for consecutive days. Now while all the symptoms are resolved, child has gained the appetite, child has started accepting orally, edema is settled, you need to sensitize the parents to how to take care of the child, how the child need to be given feed, what is the importance of sensory stimulation of the patient, and what is the importance of the feed, and hand hygiene need to be practiced. Thank you so much.